Approximately 10% of adults suffer from type 2 diabetes, or T2D, worldwide, with 40% of them developing chronic kidney disease, or CKD, which increases the risk of all-cause and cardiovascular, or CV-related mortality. Current guidelines suggest the use of renin-angiotensin system, or RAS inhibitors, and anti-hyperglycemic agents like sodium glucose cotransporter 2 inhibitors, or SGLT2Is, or glucagon-like peptide 1 receptor agonists, or GLP-1RAs, to decelerate the development of CKD and heart disease in patients with T2D. However, despite proven benefits and optimal use of guideline-based therapies, patients with T2D continue to progress to kidney failure or die from kidney or CV-related causes. Therefore, new therapeutics are required to reduce CKD progression. To this end, researchers from USA summarized the pathophysiological mechanisms that lead to T2D-associated CKD while assessing the possible benefits of newer therapeutic agents that target these mechanisms to reduce the residual risk of negative renal and CV outcomes in diabetes-associated kidney disease. Overactivation of mineralocorticoid receptors, or MR, promotes inflammation and fibrosis, the key pathophysiological processes involved in kidney pathogenesis and progression in the kidneys and heart. This makes MR an appropriate treatment target for therapeutics that intend to slow CKD progression and negative CV outcomes in patients with T2D. Additionally, 2 recent clinical trials have shown that finerenone, a novel selective nonsteroidal MR antagonist, significantly reduces CKD progression and negative CV events compared to standard treatment regimes. This promising drug introduces a novel approach to target MR overactivation independent of hemodynamic and hyperglycemic pathways. To summarize, combining therapeutic drugs that have complementary mechanisms of action, like anti-hyperglycemic drugs, RAS inhibitors, and MR inhibitors, could mitigate the continuing risk of negative CV events and CKD progression in patients with T2D.